Well, thank you very much for Professor Scotté for your invitation, and I would like to thank all of you for your attention. I will be speaking about cutaneous adverse events to radiation therapy. These are my disclosures with industry, and I think that it is very important as a matter of background to understand the importance of radiotherapy. As you can see here, radiotherapy and the utilization of it against cancer is used in a variety of solid and liquid tumors, and it is estimated that 52% of cancer patients will receive radiation at some time during the course of their illness. And it is important to note that from a dermatologic perspective, it doesn't seem that the cancer is being targeted, but rather the skin is being targeted. Because as you can see here, once radiation is administered to patients, a sequence of events will occur, including acute effects of radiation and chronic effects that we will be going over the presentation in detail. And the consequences of dermatologic toxicities to radiation are considered to be fourfold. They have a psychosocial impact because they can affect areas of the body that are exposed to other people, and also the appearance of the skin and the outward environment. They have a financial burden, as René John mentioned, because people have to pay more for the toxicities and manage the toxicities. They have an effect on physical health because these toxicities can be very painful and can lead to life-threatening or life-altering infections requiring hospital admissions or antibiotics. And then finally, what is considered to be the most important consequence of dermatologic toxicities in cancer patients is that they can alter the consistent dosing of either systemic agents or radiation. And as you can see here, the targeting of the cancer is also accompanied by targeting of the skin, because in the epidermis, which is the outermost layer of skin, as well as the dermis, almost every single cell that is resident in those structures is affected by radiation, and the application of radiation will result in a synthesis of all these inflammatory chemokines, as you can see here, and also a variety of superoxide radicals, and also other chemokines in endothelial cells, dendritic cells, and fibroblasts, as well as immune cells, which will lead to the clinical signs and symptoms of radiation dermatitis, which include pruritus, pain, and loss of the structure of the skin. So the early events of radiation are included here as they affect the skin. Initially, patients will present with erythema, and then this will be followed by hair loss in that area, dry skin, and then followed with additional administrations of radiation with other changes as described here. And the most feared events are moist desquamation and ulceration, which represent nothing other than disruption of the barrier of skin, and in the skin providing its normal structural support. And these are two examples of patients with acute radiation events. As you can see here, the characteristic moist desquamation, hyperpigmentation in this patient, and in this other patient, as you can see here with head and neck cancer, also edema, erythema, and secondary infection. And secondary bacterial infections are very common in patients receiving radiation. In fact, it is probably the most common reason for referral to our dermatology clinic in New York from the radiation oncology department. As you can see here, in this patient with breast cancer, the hallmarks of secondary bacterial infection include the formation of these yellow or brown crusts over the area, or in this head and neck patient, as you can see here, the characteristic formation of the brown crusts are always indicative of infection when accompanied by this abundant purulent discharge. So these are the hallmarks of secondary bacterial infection. So please have a low threshold for performing bacterial cultures whenever you see a patient with any type of desquamation or discharge. And very few studies have analyzed the incidence of this. The first one was done at MD Anderson Cancer Center, in which only 6 patients were reported, all of which had severe radiation dermatitis and had bacterial infections as listed here. The largest study that has been published so far has been done in Ataturk in Turkey, and in this study, 62 patients were analyzed of all grades of radiation dermatitis, and infections were reported in 23% of these patients, and the risk was greater, not surprisingly, with a higher grade radiation dermatitis. The most common pathogens that were found in that study were methicillin-resistant staph species, followed by Candida and methicillin-sensitive staph species. And now I will be going over management strategies to prevent radiation dermatitis. But I would like to start first with management with preventive strategies that have not shown to work. And the one that has been probably studied the most and has been the least effective is trolamine or biafine. Trolamine or biafine has been investigated in large randomized studies conducted by RTOG and others, as seen here, for breast and head and neck cancers, and with a significant number of patients. And what is important about this is that biafine or trolamine has always been negative, and in fact, the control arm in some of these studies, such as calendula, which is a plant-derived moisturizer, has even been more effective than the trolamine or biafine. So the recommendation is not to use trolamine or biafine. What has been effective and has been demonstrated in randomized studies as well in both breast and in patients that have received whole brain radiation is the use of soap and water to wash the area. And this is one of such studies that was published over 10 years ago. Patients were randomized into either no washing of the breast area and the axilla to soap and water washing, and patients were assessed weekly. And as you can see here, grade 2 or 3 radiation dermatitis was significantly reduced from 57% in the control arm to 36% in the axilla and chest that was able to be washed. So many patients were happy that now they were able to wash their body during the 5 or 6 weeks of radiation. Another study that has been published is with the use of Aquaphor, which is a topical heavy ointment compared to hyaluronic acid. In this study, patients receiving radiation for breast cancer were randomized into either of these arms, and they were assessed weekly with CTCAE. And what is interesting about this is that, as you can see here, there was a reduction or a lower incidence of grade 2 or worse radiation dermatitis with the use of this heavy ointment compared to hyaluronic acid. And in fact, in the US, anecdotally, many institutions use Aquaphor to prevent radiation dermatitis. However, I think there are better options. For example, the use of a high-potency topical steroid has been reported in over 5 randomized trials, the largest one of which I am showing here. This study was conducted from the North Central Cancer Treatment Group based at Mayo Clinic, and patients with breast cancer were randomized into either the use of mometasone, which is a high-potency steroid, daily, or placebo. Patients were assessed weekly using the NCI CTCAE grading system or a patient-reported outcomes tool. Unfortunately, when patients were graded with the CTCAE grading system, the maximal radiation dermatitis was no different between the two groups. However, we do know that deficiencies of grading these types of toxicities from an objective standpoint in terms of really capturing, as Joel mentioned before, what the patient is feeling. So what the same investigators did later is they analyzed the patient-reported outcomes. And what is interesting is that the CTCAE grading did not correlate with patient-reported outcomes. And symptoms associated with radiation dermatitis were significantly lower, including discomfort, itching, and redness in the mometasone-treated arm compared to the placebo-treated arm. So in summary, the only topical agents that have shown benefit for the prevention of acute radiation dermatitis are topical steroids of high potency applied daily. For anal cancer, on the other hand, topical steroids have not been tried, and this is unfortunate because, as you may know, 100% of patients that are treated for anal cancers develop radiation dermatitis, which is grade 2 or worse in 43 to 78%. So what these investigators conducted was a study using this topical dressing, which contains non-adherent nanocrystalline silver. And this is frequently used in burn wounds for its antimicrobial activities, and it is considered to be more effective than silver sulfadiazine for burn wounds. So it is antimicrobial and is believed to have wound healing properties. In this study, that was a small study, compared to historical controls, the silver leaf nylon dressing was compared to historical controls, and photos of the patients were assessed by 10 investigators, and the results of the study are shown here. The mean RTOG score was less than half of that from the historical controls when the silver leaf nylon dressing was used. And to me, this makes sense if the product is even as much as antibacterial. Reducing the bacterial flora in such a contaminated area of the body will certainly reduce the possibility of secondary infections and severity of radiation dermatitis. So my suggestion would be to use topical antibacterials for patients receiving anal cancer, treatment with radiation. In terms of adding other agents to radiation, we all know the Bonner trial in which cetuximab plus radiation was used in these patients. Surprising to many of us was that mucositis and radiation dermatitis was no different between the radiation therapy only arm and radiation plus cetuximab. Cetuximab blocks the growth of skin cells, keratinocytes. It was surprising it would not affect this. However, a meta-analysis that was conducted by A.J. Tewani, who is a radiation oncologist, showed that when you analyzed all the studies, the risk for severe radiation dermatitis when you add cetuximab to radiation is more than doubled, as seen here. And these are the forest plots to show this. And even mucositis was increased in terms of its risk of severity by almost double when cetuximab or an EGFR inhibitor was added to radiation. And this, of course, was followed by several reports. The first one from Germany, as shown here, in which a cetuximab-treated patient showed us grade 4 radiation dermatitis. And then subsequent reports have supported this notion that adding an EGFR inhibitor to radiation leads to greater skin toxicity. Subsequent to this, also other targeted agents such as the BRAF inhibitor vemurafenib, when used in combination with radiation, as you can see here, lead to greater skin toxicity. So I believe that it should be taken with caution, the use of these targeted agents and concomitant radiation. So briefly, I will be speaking about late events which occur after at least 45 grays have been administered and occur at least 6 weeks to months after radiation therapy. Some of the most common events are chronic radiation dermatitis and usually start within the first 6 to 12 weeks. And you can see here the non-healing area of a woman with radiation to the chest wall, or fibrosis to the radiation area as seen here. And this usually occurs even after the radiation has been completed, but within 1 year. And it's reminiscent of the findings seen in scleroderma. So there have been several randomized studies comparing the effectiveness of pentoxifylline and vitamin E for the treatment and the prevention of superficial fibrosis after radiation. And this is just one of such studies, one of the first that was reported, showing that in 24 patients with 29 sites of radiation fibrosis, you can see here the combination of pentoxifylline and vitamin E provided the greatest benefit in terms of reducing the areas of fibrosis. So pentoxifylline and vitamin E is currently recommended for the treatment of radiation-induced skin fibrosis. Another late-term issue is persistent alopecia, and although there are no effective measures for this, I think the use of topical agents that are already approved, such as minoxidil, have been shown to be anecdotally effective in my experience. The greatest incidence of radiation-induced persistent alopecia is when you combine chemotherapy with radiation. And nowhere was this more evident than in this study of 227 children treated with chemotherapy plus radiation, in which 70% developed persistent alopecia seen here, compared to only 30% of those that had radiation therapy alone. The risk factors were children that were older than 11 years old and those that also received chemotherapy. Another consequence, late-term effect of radiation is the increased risk of second cancers, most notably basal cell carcinomas. And the childhood cancer survivors cohort, which is an analysis of over 16,000 patients that had cancer when they were children, analyzed the most common second malignancy in these patients was basal cell carcinoma or non-melanoma skin cancers, occurring in 41% of these malignancies that were reported. So radiation therapy is associated with a 6-fold greater risk in the development of basal cell carcinomas. In this analysis of over 16,000 patients, 90% of tumors were within the radiation therapy field. And a risk in terms of patients being very young at the diagnosis of cancer provided a greater risk. You can see here an example of one of such patients. This patient received radiation to the back as a child, and you can see here at every number, 1, 2, 3, 4, 5, and 6, 6 synchronous basal cell carcinomas occurring in this area, and these patients will continue to develop basal cell carcinomas for life, which will lead to additional morbidity and additional cost to their care, not to mention their effect on quality of life. And then finally, another toxicity that is more of cosmetic importance is the development of these telangiectasias, or dilated blood vessels that occur months to years after radiation, as you can see here. And interestingly, the reason I bring this up is because there are effective treatments for this. A pulse dye laser, which is something widely used by dermatologists, was used to treat this. And as you can see here, it completely abolishes the development of these telangiectasias. And any patient you have with these telangiectasias that can be bothered by these or by the radiation tattoos in the chest, these can be easily treated with lasers by a dermatologist in your practice or in your city. And I feel that patients benefit greatly from that. So to conclude, skincare is of great importance in patients treated with radiation for the reasons that we have already seen. It is important to treat patients early and proactively, for example, with the use of prophylactic topical corticosteroids to prevent radiation dermatitis, a low threshold for bacterial cultures to treat second bacterial infections, which occur in about a quarter of these patients. And then these radiation skin toxicities will increase in importance as more radiation is used in the adjuvant setting. Patients are less willing to tolerate toxicities. As we have seen, when radiation is combined with biologic or chemotherapy, skin toxicities will be worse. And as was mentioned by our previous colleague in the presentation about cardiac events, as patients are living longer, a greater emphasis is placed on other issues, including quality of life issues. And patients having long-term side effects from radiation will be significantly affected. I wanted to conclude by mentioning one study that I found before coming to the meeting, which was a study from Korea, in which they studied the effect of laughter on radiation dermatitis in patients with breast cancer. So this study was done in Korea. I had never heard about this before, but these patients were randomized into either laughter therapy or no laughter therapy. Patients were graded using RTOG, and there was about a 20% reduction in grade 2 or worse radiation dermatitis, which was not significant. So I think it was an interesting observation, and with that I would like to conclude. I always like to conclude my presentations by showing two interesting cases, the case on the left and the case on the right. I think by now all of you know exactly what these are. The case on the left is a case of acute radiation dermatitis in a woman with breast cancer, and the case on the right, it is sun damage in Alain Delon's forehead. Thank you very much.